So my talk today is entitled Neurointerventional Frontiers in Ischemic and Hemorrhagic Stroke. And I'm going to try to give you guys a pretty good idea of the different types of stroke patients you're often picking up. Uh, and uh, and so
Relax. It's
we're
just
gonna try to go
daddy.
from basically um, you know when you pick them up to all the way through the hospital and hopefully home. Now, five learning objectives is Brian put in the flyers. Differential ischemic stroke versus hemorrhagic stroke in the field, and the challenges there. Recognize some key signs and symptoms using BFAST and clinical cues. We'll talk a little bit about pre-hospital stroke scales and know when to activate a stroke alert. Identify evidence-based interventions and time-sensitive treatments, and optimize destination decisions to reduce door-to reperfusion times. As well as I'm going to go extensively into some of the interventional therapies and give you some case examples of patients that we treat that you have brought to us in the hospital. So I think everybody's familiar with this, the BFAST, kind of clinical cues. And one of the important things to recognize is adding the balance and the eyes in addition to the face, arm, speech, and time really gives you an opportunity to catch some of those very difficult to catch posterior circulation strokes. And so patients are off balance, we've got vision problems, double vision, that often isolates to the posterior circulation. And so that's something to be aware of and to use, when you screen your patients in the field. Um, and you can see that there's a pretty high dispatcher sensitivity for stroke, depending on which of these tools that we talk about are used. One of the good things is the sensitivity is pretty high, meaning
Mhm.
you guys are picking up
Almost.
most of the strokes. The specificity, though, of course, for these different scales is very variable, and I think, we want to be, as a screening tool, very sensitive. Specificity would be nice, but you don't necessarily have to be specific because we're going to do a lot of screening once they get to the hospital, and we can rule out less urgent non-stroke syndromes. Um, some of you may be familiar with some of the different pre-hospital stroke scales, and you can see that there are a lot of them. Um, Brian, what are we using in Long Island?
We're using still Cincinnati. We currently in Nassau don't have any mechanism to divert
Yeah,
to a comprehensive or thrombectomy capable center, but that's coming.
that's
It's in the
coming.
works.
Yeah, and we'll talk a little bit more about that, but you can see the Cincinnati scale, the face, arm, speech, kind of the simplest one, right? I think, the Lamb scale, adds a few, additional features, and you can see that there are, some other scales as well. I think one of the things, gaze deviation, if you guys see a gaze deviation, in other words, neglect on one side, that is often a very specific, and more sensitive for large vessel occlusion, and so, conjugate days deviation, and you can see what the cutoff is for what they think is an LVO. But I think if they're, I think taking them to a primary stroke center, as long as they have any of these, scores, I think you should definitely give a pre-stroke alert to the hospital that you're going to, if you can, if that capability is available. And this will prepare us to screen these patients very rapidly once they get to the hospital. Um, you can see that, the real world impact, of using these scales to send, potentially patients, as we may in the future, direct to thrombectomy capable centers. You can increase the transport directly to those centers and potentially save some time. You can see that in some cases when they use the race alert, they decrease the time from 130 minutes, door to puncture down to almost an hour, which is incredible. In Denmark, they made significant, progress, saving about 50 minutes, almost an hour, bypassing primary stroke centers. So I think that's something that I think is still being, kind of evaluated in many communities. It really depends where you are, and it has to be kind of a local, kind of specific, kind of situation. And I think that it's good that we're exploring that in Long Island as well. So let's get into some case presentations, and we're going to start off with ischemic stroke. Uh, and I think you're all aware of large vessel occlusions, and we're going to talk about large vessel occlusions briefly, but then I'm going to also get into kind of medium vessel occlusions, distal vessel occlusions, and some of the stroke syndromes that you might see. So starting off, let's get into some anatomy. And I know this is not something that you guys are familiar with, and I don't expect you to know or to learn it in some kind of major, like memorized kind of way. But I think it's important for you guys to at least be familiar, with some of the anatomy. So this is an example of the internal carotid artery on an angiogram, an ICA injection. And you can see the internal carotid artery goes into the skull about here, into the petrous segment, goes through the cavernous segment, then comes out of the into the intracranial segment here. And this is the middle cerebral artery. And on the lateral, similar, cervical, petrous, cavernous, ophthalmic going to the eye. And then you have the MCA. This is the MCA. It's actually a big PCA, actually. This is the posterior cerebral artery that has what we call a fetal origin, meaning it's kind of like when you were when you were a neonate or when you were in the uterus, it often will come off directly from the carotid artery. Later on, this kind of segment involutes and it comes off the basilar, but we can see these in adults, the normal variation. And these are the middle cerebral artery branches, going to the different parts of the brain. And we'll get into that real quick here. This is what we call an LVO. When it's in the ICA or the M1, the entire territory is at risk. As we go further out, kind of like mile markers on a highway, you go into what we call the M2, the first branching divisions. The next branching divisions, M3, we're getting further out. And then M4, and then finally the terminal branches, or the M5. And we're going to talk about stroke interventions in the LVO, M2, and even in some cases as far out as the M3. And why is that we consider that? Well, we'll talk about that as well. But you have to remember that, each of these arteries goes to an important part of the brain. So we have what we call the orbital frontal group. And when you name arteries, you kind of name them by where they go. So the artery that goes to Dr. Mangla is called the Dr. Mangla artery. The artery that goes to Brian Johnson is called the Brian Johnson artery. So it's kind of named by where you're going. So the artery to New York is the New York. It's kind of like highways. You have, highways that are named after the city that they go to. And so this is kind of the opercular frontal group, the Rolandic group, the angular or, kind of parietal group. And we have the temporal lobe group, right? And so each of these are different territories. You can see they supply a significant part of the brain. And why is that important? Well, that's important because all those brain areas have important function. It's like real estate. What are the three most important factors in real estate? Anybody?
Location.
There you go. You got it. Perfect. Location. So we divide the brain kind of into halves with what we call the central sulcus. And the anterior half, or what we call the precentral motor gyrus, is the primary motor cortex. If we go further anterior, we have the accessory motor cortex. We have the motor language cortex, or Broca's area, right? And then this prefrontal cortex is all the complicated executive functions. The fact that you got to pick up your kids, go to work, make breakfast, all that stuff gets done, kind of out here. When we go more behind the central sulcus, we get into the primary somatosensory cortex, and then the accessory somatosensory cortex. Here we have the receptive language function. And then receptive and expressive language function have a lot of communications, and that's where we can get mixed aphasia. And then back here we have the visual cortex, and then the auditory cortex, and memory, and a lot of other things are in the temporal lobe. And so obviously there's a lot more to it, but this is kind of a generalized diagram of where these things are located. And why is that important? Well, because the different branches of the blood vessels are going to supply those different areas. If you see these red areas on this side view, that's the middle cerebral artery. The blue areas are the anterior cerebral artery, and you look, from the top, you can see, the medial aspect of each hemisphere is the anterior cerebral artery and the middle cerebral artery, and then the green areas are the posterior cerebral artery. And this is for the anterior circulation. And then you see these yellow areas are what we call watershed territories. So those are areas that can be at risk when essentially you have low blood flow states or low blood pressure situation. Or if you have a major large vessel proximal occlusion, sometimes these watershed areas, if let's say the carotid artery is completely blocked, and you've got good collaterals, or just you got some collaterals but not good enough, sometimes you'll get a stroke in the contralateral hemisphere in their watershed territories. And these will all look different. And then you got the basal ganglia and other areas that are also supplied.
That's right.
And once again, why is that important? Location, location, location. Because if you look at what we call the homunculus, this is the original homunculus that was Penfield's homunculus from 1948. And there's been a more modern version of it in 2022 that came out. But essentially what it says is, you see where the hand distribution, the motor distributions are for the hand, very big. The hand's a big deal, very well represented on the brain. And then you also see where the legs are. And so the hand is going to be MCA territory, right? Where the legs are more anterior cerebral artery territory, ACA. Essentially, if you look at the old version, it was like, the big hand was hugely represented. You see the big thumb, the big fingers. Our fine motor movement requires a lot of brain power, where the leg kind of hangs down over the medial aspect of the brain. And then you can see the face and the tongue, right, are very well represented, very important. And you can a little bit further lateral, then you can see that these are kind of the intervening areas, those watershed areas, kind of, that are involved in kind of coordinating a lot of these actions, in addition with posterior fossa and the cerebellum. And so when we look at stroke syndromes, if you see a patient that has more leg weakness than arm weakness, and apathy, urinary incontinence, gait apraxia, you're thinking more ACA. If you have more face and arm than the leg, in other words, the leg is stronger than the face and the arm, and there's sensory loss and vision loss in, let's say, homonymous hemianopsia, which means, in both eyes, you're missing one field, the lateral field in both eyes, not a monocular blindness. Monocular blindness is also potentially stroke syndrome, central retinal artery occlusion, where you block the ophthalmic artery and the artery that goes to the retina. Language problems are also more common with MCA syndromes. PCA syndromes more commonly have visual problems, visual agnosia and alexia with agraphia. As we talked about, those watershed strokes, they can have more kind of proximal arm and leg weakness, a man in the barrel kind of situation, which tends to be more equal. Arm and leg are both weak. And lacunar syndromes, where you get small blood vessel strokes, once again, you don't have to have a huge stroke to have severe deficits, because if you have a small stroke in specific areas like the posterior limb of the internal capsule or in the brainstem, you can knock out all the cortical fibers that are going down to the spinal cord and take out face, arm, and leg and be completely plegic. So when you see a patient with face, arm, and leg complete plegia, yes, it can be a large vessel stroke, but oftentimes it can be a small vessel lacunar syndrome that's knocked out a critical area. When we go to the posterior fossa, once again, we've got the bilateral vertebral arteries that form the basilar artery that give off the posterior cerebral arteries. And we have what we call the posterior inferior cerebellar, the anterior inferior cerebellar, and the superior cerebellar, which goes along with where they go. The posterior inferior aspect of the cerebellum, the middle kind of anterior inferior aspect of the cerebellum, or the superior aspect of the cerebellum. And you can have corresponding stroke syndromes, that correspond to those vascular territories being blocked. If you have a basilar artery occlusion, you can have what we call locked-in syndrome, which is the ventral pons, where they're basically completely quadriplegic and they look like they're in a coma, but they're actually awake. They know what's going on, but basically what you've done is you cut off the top of the brain from the rest of the body, and so people can only blink or have minimal eye movements, and they're not able to, they're completely, they're locked in. Um, Top of the basilar, variations of that kind of, stroke include altered consciousness, oculomotor dysfunction. So if you see eye movement problems, you're worried about posterior fossa, visual field deficits. If they have blind spots, you're worried about posterior fossa. If you go down lower into the brainstem, posterior inferior cerebellar, you get vertigo, trouble swallowing, hoarseness of their voice, Horner syndrome, limitaxia, you know, the anterior inferior cerebellar, you can get ipsilateral facial palsies and hearing loss, vertigo, ataxia. So vertigo, ataxia, facial cranial nerve deficits, these are all evidence of potential posterior fossa stroke syndrome. Now, in terms of interventions and time-sensitive treatment, I think the updates for the guidelines are, that we should obviously definitely give IV TNK within 4.5 hours. In some cases, there's an extended window up to 9 hours, but that's kind of a very limited, set of patients, and they require advanced imaging with MRI or perfusion to do that. It's not something we're doing, kind of system-wide at Catholic Health, and I'm not sure that it's something that really applies to a ton of patients, especially when we're dealing with stroke programs that have endovascular capability and thrombectomy capability. And so basically anybody with a stroke scale score greater than, I would say, 2 these days, that has a large vessel occlusion, we would consider for stroke intervention. And in terms of field interventions with no benefit or harm, I think when we look at some of these things, there's really been no major added benefit shown with any of these things. And so generally, I think the biggest role is for EMS is to identify, that a patient may be having a stroke, to stabilize them in the field. I think, not being intensive blood pressure control, but getting their blood pressure down to a reasonable level if possible, while in transport, and communicating to the, to the receiving hospital that you're coming. So let's get into some interesting cases. And this we'll talk about large vessel, medium vessel, and distal vessel occlusion. So here's a diagram or, an infographic that shows you kind of what we're dealing with. Let's pretend this is the middle cerebral artery, and there's a big clot sitting there in the M1 segment. There's the bifurcation into the M2s. And so what we do with, in neurointerventional is we will, this is not an accurate picture of exactly the kind of catheter, but it's just kind of a AI diagram that I was able to create, where we take a aspiration suction catheter right up to the clot, and then we put a vacuum and we try to suck the clot in and ingest it. And if we can ingest the entire clot, that's great. In some cases, what we'll do is we'll get it corked, within the catheter, and then we'll slowly pull it out. And hopefully we will completely restore blood flow to the artery. So that's what we would call direct aspiration thrombectomy. And that's kind of my first line approach because it has I have pretty good success with it, and there's less trauma to the vessel wall. Then the second approach that sometimes we use, which is called a mechanical thrombectomy using a stent retriever. And that essentially is where you put that catheter up through the clot, and then you open up this metal cage inside the clot. And that cage you let sit there for about 2 minutes. And what that does is that clot is very sticky, like mucus, often. Sometimes it can be calcified, but oftentimes it's got a lot of, kind of cohesiveness and stickiness to it. And what you're trying to do is get that clot engaged into the stent retriever, so that it will be stuck to it. And then you basically slowly peel it off of the vessel wall, because the clot not only does it stick to itself, it also has what we call adherence or and sticks to the vessel wall. So you got to kind of peel it off, and hopefully, and we also often will use aspiration and the stent retriever in cases where the aspiration doesn't work by itself, in kind of an attempt to engage and grab the clot and pull it out. So this is probably old news to you, so I'm not going to spend a lot of time. But back in 2015, 2016, 2017, all these randomized trials came out looking at all sorts of different, types of stroke patients and different windows of opportunity. And we saw that with all of these trials, whether dig the broadest group, which was Mr. Clean, all comers, right? Or you did more select populations with perfusion imaging and longer windows. All of these trials showed a significant benefit of good outcomes, MRS 0 to 2, you know, 50%, anywhere from 33 to 56% versus their control groups, where you did not intervene on patients. And so this is what essentially made acute stroke thrombectomy the standard of care. And over the last 10 years, we've been building programs all over the country to allow and access to this life-saving care to our communities. And so that's nothing new there. But there are a lot of patients that don't have large vessel occlusions. The blood clot is actually smaller, or it breaks apart on the way up, like a plinko, and goes out further into the smaller blood vessels, what we call medium vessel occlusion and distal vessel occlusions. And so, if you look at this diagram, this is the carotid artery, middle cerebral, anterior cerebral. A1, M1, yeah, we know. Proximal M2, yeah, we should definitely open it. But should we go out even further and try to open arteries that are further out and causing major stroke syndrome? And why is that important? Well, 25 to 40% of acute ischemic strokes are from these medium and distal vessel occlusion. And so the question is, should we and can we help patients that have occlusions further out? Why is it different? Why is it challenging? Well, the vessels are smaller. They're more tortuous. They're windier. They're harder to get to. The clots are smaller, so maybe they respond to intravenous thrombolytics better, but it's not consistent. We still see many patients that have medium and small vessel occlusions that don't respond to TNK or TPA. Smaller vessels, it's a more complex procedure. These vessels are in the brain are not like vessels in the other parts of the body. They're much thinner, they're much more delicate. They're the risk of perforating one of these vessels or injuring them is also carries significant potential harm. But none of the previous trials really address this, because when we design clinical trials, you try to design it so you can ask a question that can apply to a very specific group. And you don't want to mix too many different types of patients, because otherwise you may cloud the trial and not really get a reasonable answer or any kind of consistent answer. But let me show you an example of a patient. 64-year-old woman, high blood pressure, SVT, heart issues, protein C deficiency, so she had some hypercoagulable state. Transferred from Mercy to St. Francis. She was at Mercy Hospital where she works. She was an employee at Mercy. Her stroke scale score, was a 7. Because she had significant left-sided weakness and language, issues, dysarthria, and they emergently obviously evaluated her. This was she was at work during lunchtime, and you can see she got the CTA and CT perfusion. And so what we have here are the perfusion maps. This half is the cerebral blood flow map, and this half is what we call the Tmax, or the time to max map. Now you can see here in this little green area on the right side of the brain, in the precentral motor cortex, that there is an area of delayed perfusion, a distal blockage. If it was an MCA, it would be the entire area, but this was a smaller territory. And on this perfusion map, the CBF map, we don't see anything abnormal, which suggests that it may still be viable. And you can see where the at-risk brain is, and then you can see, that there was essentially a mismatch between these two, suggesting that this brain is ischemic, but it's not dead. And if we get up there, we might be able to open it and save that brain tissue. Where is that location? Precentral motor in her, right? So that's going to be that dense, potential left hemiplegia, because the right side obviously controls the left side and vice versa. So when we did the angiogram, oops, let's see if I can pause it. There we go, pause. Excuse me. There is a normal artery going all the way out, right? This goes to the parietal and kind of postcentral sulcus. But here is an artery that is missing, and there's a blockage right here. So this is the MCA territory. This is the anterior cerebral artery, which is going to be more leg and in that territory. And so when we keep playing the video, you will see that this artery is blocked, and this is the area of hyperperfusion, which affected her motor language and her left arm. And so this is me navigating the wire. I've got to basically steer and get and find that blocked artery. And then I go through that blocked artery with the wire through the clot, and then pull an aspiration catheter up to the clot and suck back. And when we look at the final result, you can see the artery that was missing has now been restored. And you can see there's a little bit of like extra gray there. That's the hyperemic tissue that has been ischemic, is now receiving perfusion. Then we have to be careful and keep the blood pressure low after these interventions, because we don't want high blood pressure heads to be rushing into ischemic brain territory. Ischemic brain territory has disrupted autoregulatory mechanisms, and there's vasodilatation, et cetera. And so you can get hyperperfusion syndromes, and reperfusion hemorrhage are the potential complications of revascularization that we want to try to minimize the risk of. And so you can see that within 12 hours, her stroke scale score was a 2 from a 7, with only mild dysarthria and a mild facial droop. Her left arm was completely back. By the third day, it was to 0, and she went home. When we look at the MRI, we can see that territory that was at risk, maybe a little bit of ischemia there, but this entire area that was at risk in this medium vessel, distal vessel occlusion was saved. Endovascular therapy for distal vessel occlusion, going even further out. Once again, same kind of discussion. Distal vessels are a big problem. They can result in severe stroke syndromes. The vessels are smaller, even smaller than the medium vessels, obviously, further out and even more delicate. So even more challenging, right? So, the question is, how far can we go? And should we go? And can we help people? And when should we go? And I don't think it's an easy question or easy answer. And I think it's still something we're learning we're learning over time. There's another patient, 77-year-old left-handed woman, past measure of atrial fibrillation, presents with left-sided weakness, pretty profound endophagia. Her daughter found her this morning unable to speak. Her daughter was on the phone and with her the night before, so we didn't really know when her last normal was either. Stroke scale score was 6, came into Mercy, we transferred her to St. Francis. And then we look at the CT angiogram, basilar artery, middle cerebral artery. This is the right, this is the left. Hard to tell, but maybe a blockage here somewhere. These CT angiograms sometimes, especially for the more distal vessel occlusions, because of collaterals, sometimes it's hard to see where the blockage is. But on the perfusion maps, that's why I'm a big proponent of perfusion imaging. It's much more sensitive to large vessel or distal vessel and many occlusions. You can see these two different territories, of perfusion with preserved blood flow, which suggests collaterals. And so that we have potentially an opportunity to restore blood flow. And this is the CBF map, CBV map. There's no abnormalities there. So that suggests the collaterals are good. And that if we reopen that artery, maybe that brain will be saved. And so when we do the angiogram, you can see here 2 different branches, distal branches. This one here going to the parietal lobe, and this one here going to the precentral motor cortex. If you play it out, you will see these 2 distinct areas of hypoperfusion. And You can see some collaterals coming back, not a ton, but there's some collaterals. See if I can get the next picture. So you can see these wedge-shaped defects right here in that, post-central sulcus and parietal area. And this is kind of in the anterior motor area. Now, this is not an LVO, but it's a DiVO, right? You can see that we're getting into the distal branches, and you see how small those vessels are and how windy they are. So what I did was, from this position, I gave 4 milligrams of intraarterial TPA. And this was, basically to try to see if maybe the TPA directly administered would potentially dissolve and lyse these clots. And then what I did was I went in with a wire, and you're going to see how I navigate across this blockage. As you see, what we're doing is I'm slowly poking it and following the course of the vessel. And then I take the aspiration catheter and I pull it all the way up to the vessel, or to the blockage, and I aspirate and suck back. And I'll show you the next one. We got this one open. This one I also tried to go after, but you can see the curves are very tight. I was not able to get the wire and the catheter up that far to get that open. And so when you look at the pre, where there was this posterior and this anterior blockage, and the post, you see that pre, we got this artery opened. And this one, unfortunately, I couldn't open. And when she did have some improvement, but she still had a pretty significant left upper extremity weakness, where she was 3 out of 5 proximally and distally 0 out of 5. Her left lower extremity was 4 out of 5, and so she was better. But if you look at the CAT scan, you can see that the area that we were able to open, which was more posterior, was saved, but the area that we weren't able to open went on to a completed stroke. And so what that shows us is that if we're able to open these distal vessels, we can save a lot of brain tissue. Now, how safe is it? Do we have the right tools? Which patients should we go after? Those are still open questions. And so we've done, there have been some preliminary trials that have been done. Now, I would argue that they're not the best. Some of the early ones have not been designed that well. And I think they used a stent retriever in many of these distal vessel occlusions, which I don't think was a good idea, because I think there's more trauma. And I think that if we use a direct aspiration approach, I think we have less risk of harm. But these early trials, the first few, were, pretty neutral, or, in terms of outcomes, good outcomes. This one discount trial showed a worse outcome with intervention and a high rate of hemorrhage. So I worry that those operators were being a little too aggressive, and they halted that trial. But the most recent trial just came out in 2026, the Oriental MeVO trial from China, which was significantly better design, showed a significant benefit, 58% good outcome versus 46% good outcome, in not that much of a higher rate of hemorrhagic conversion. So I think as we evolve our techniques, I think we have a better chance of improving outcomes. What you can also see, which I think was very interesting, is that even the control group, people that we did not intervene on with medium and distal vessel occlusions, about 10 to 15% of them died. So these are not minor strokes, and so what my general approach to these is, if the patient has a significant disabling stroke, I would say NIH stroke scale of 6 or 8 or greater, and we think we have some potential salvageable brain tissue on these brain perfusion maps, that I think it's a reasonable thing to offer emergent stroke intervention to those patients, because the disabilities, 46% good outcome, that's not good. Even 60%, that means 40% of people are disabled. 40 to 60% of people are disabled with these medium and large and small vessel occlusion. So I think, in terms of the EMS, role, I think, you guys identifying these strokes early and quickly, and then transporting them to, whether it's a primary stroke center or a comprehensive stroke center. I mean, I think that one of the nice things is that our Catholic health system is we're a very well coordinated system, and we have very fast interhospital transfer. And so even if the triage is done at, let's say, Mercy Hospital or St. Joe's Hospital, when we know it's an LVO, we can activate the team very quickly and have the team there at the other hospital, whether it's Good Sam or St. Francis at this point. We can activate our teams and take that patient directly from transfer directly to the cath lab and bypassing all the ED, testing. And so by the time you get to the groin and reperfusion, you've not lost as much time as you think you will. And I think the key there is door in, door out time, in your hospital, in your primary stroke center. I think it's getting that door in, door out, not to that 174 minutes, but closer to like 60, or no later than 90 minutes. And I think this is, what their door in, door out, DiDo time target was 120. Personally, I think we can, we do better than that here at Catholic Health. I think we can basically with CTA and perfusion imaging, we know within 45 minutes whether or not a patient should be transferred. And then it takes about another 15 to 20 minutes for us to get an ambulance there. And by the time, they roll the patient out, it's another 15 minutes. That's less than 90 minutes, I would say, in the vast majority of our cases, which is what we should be shooting for. Now, we're going to get into the hemorrhagic topic here as the second half of this discussion. And one of the questions is, how do you tell an ischemic stroke versus a hemorrhagic stroke? And I'll tell you right now, this is a difficult job. This is very hard to do clinically. There are some key features, though, that you can look for that will lean towards hemorrhage. If they have a bad headache, odds ratio is much higher, because, subarachnoid hemorrhage, brain aneurysms, major intracranial hemorrhage from hypertension will often present with a bad headache. Ischemic strokes, much less likely to have headaches. If their Glasgow coma scale is very low, then you're often also very suspicious of hemorrhage because ischemic strokes, they're often awake and trying to talk to you, and they're much more alert, but but they have major deficits. So a very low GCS, blood pressure being sky high, that's a very suspicious sign because number one, it could be hypertension that caused the bleeding. Number two, the bleeding could cause severe hypertension, right? So whether it's causative or reactive, it could be either or, but very high blood pressures can sometimes point to hemorrhagic. If you have all three of these, hemorrhage goes way up on the list, and men also are at high risk because of high blood pressure and some of these other issues. So what's our field take homes for these things? Well, treat every stroke as it could be hemorrhage or LVO because the exam findings heavily overlap, right? High blood pressure, severely depressed consciousness should, however, increase your risk for hemorrhage, and I think, this is up to you guys in terms of what you use, but I think, and what your latest evidence guidelines are in terms of what types of medications to use to lower blood pressure in the field. So what causes hemorrhagic stroke? Well, hypertension is number one, right? High blood pressure is, probably the most common cause of hemorrhagic stroke. But what are the other potential treatable causes? And we're going to talk about brain AVMs, which is this is an example of. This is a catheter or microcatheter going out for a brain AVM, and this is basically in the posterior fossa. You can see this huge aneurysm, and there's essentially a fistula, a connection with the arteries going into the veins. That is a short circuit, and we'll talk a little bit more about that. So there are different subtypes of AVMs. There's what we call the parenchymal AVMs, dural AVMs, venous malformations, cavernous malformations, capillary telangiectasias. This category of AVMs are the low risk category. Low risk of bleeding, low risk of disabling, hemorrhagic strokes. This is the group dural AVMs and PL AVMs that are the highest risk for hemorrhagic stroke. What is an AVM? Essentially it's a focal abnormal tangle of dilated arteries and veins that form a short circuit, right? Normally our arteries go, as I showed you earlier, large artery to medium to small to capillaries to brain tissue, then coming out small veins to medium veins to big veins, kind of a sequence, scaling down, scaling back up. But what happens in AVMs is you have a connection that is, at a pathological level where you get this high flow going into these abnormal vessels, and then it drains into, abnormal veins. And PL AVMs like this are things that people are generally born with, while dural AVMs, are acquired lesions often seen in older patients as a result of some kind of pathology related to the veins in the brain, which include some kind of clotting or occlusions often. And so, I'm not going to get too much into that, just I wanted to give you guys a good introduction on some basic AVM. So no intervening capillary bed, no intervening neural parenchyma, low to high flow shunt with red oxidated veins, and they can get bigger with age. They can be on all the different locations, the parietal lobe, frontal lobe, temporal lobe, cerebellum. They're not super common. I would say probably we see about, 30 to 50 ruptured brain AVMs every year in the New York City, Long Island area, all hospitals combined. We probably see about another 100 to 200 unruptured brain AVMs, just because of imaging and the scanning that we do. If AVMs have aneurysms, they're more likely to bleed. That's one of the risk factors. If their venous drainage is deep into the deep venous system, as opposed to the superficial venous system, they're more higher risk for bleeding. Genetics, we don't really have, any very kind of specific genes that we've identified. There must be some congenital nature to these or some genetic nature to these, but we don't know what that is. There is a rare condition called hereditary hemorrhagic telangiectasia, HHT, where patients do have a higher risk of brain AVMs, and that is sometimes seen in some patients. How do brain AVMs present? Well, you can see the vast majority of the ones that we find are from hemorrhage, seizures in 30%, headaches, neurologic deficit, and other asymptomatic. Now, this is an old paper. I would say that this other asymptomatic has grown dramatically because we now image patients way more than we used to. Anytime they come in with a headache, anytime they come in with a problem. So I suspect that that number is probably 2 or 3 or 4 times as high now. So let's take a look at a patient. This is a 19-year-old, right? Young guy, he's just a kid. He presents with life-threatening left frontal temporoparietal interparenchymal hemorrhage, complete right hemiparesis, complete language loss, and he progressed to a coma, right? So this suggests hemorrhage. When we look at his CAT scan, big, huge left temporal frontal hemorrhage. This is on the CAT scan before the surgery. Big hemorrhage, left temporal and frontal. This is, I think, the same kind of picture. Let me just double check. Yeah, similar. Oh, that's the pre, and this is the post. That's what I wanted to show here. This is post-evacuation, post-hemicraniectomy. And so what the surgeon did here is basically, you can see, they've removed the skull, what we call a hemicraniectomy, where you remove it, and they went in and evacuated as much blood as they could safely, from that hemorrhagic pocket. And why do that? Well, basically what you want to do is decrease the mass effect on the adjacent brain tissue, and you want to decompress the swollen brain so it has room to kind of expand out and, and doesn't really get pushed in which can cause herniation and mass effect, right? And so you can see on this picture, there was significant, compression. You see all the ventricles are kind of shifted over a little bit, and on this post picture, you can see that these ventricles are expanded up again, and the pressure has been relieved. So we brought this patient over because 19 years old, why did they have a big brain hemorrhage? They're, otherwise healthy, skinny guy, no history of hypertension. So one of the biggest things you would worry about is a brain AVM or some kind of aneurysm. Aneurysms are not as common in young people because aneurysms are also kind of an acquired phenomenon. It's not something you're born with. Aneurysms are something that generally develop over time based on age, high blood pressure, and other risk factors. And we'll talk about those, briefly in a moment. So here we have the angiogram, the first angiogram, and we see something abnormal here. See this vein coming in? This is coming in early. It shouldn't come in till now, but it came early. And so an early draining vein is the hallmark of a brain AVM, because that tells you that there's been a shunt in here, a short circuit. On the side view, once again, you will see right in this area, right here, there's that early draining vein, which is coming in way early compared to all the rest of the vein. It's coming in before it should, which tells you there's a high flow shunt. So we didn't treat that AVM emergently because at this point, the patient was in critical care. We need to stabilize him. We essentially decompressed him, and then he went through his inpatient, and thank God he survived everything because he was obviously at risk for dying. And over the next few months, he recovered. He got his bone put back, and when he came back to see me 4 to 6 months later, he looked incredible. I mean, compared to what he was when I first saw him in his first admission. He had some mild word finding difficulties, mild right upper extremity weakness, but otherwise he was talking, walking, talking, understanding everything. And when we did his follow-up MRI, we can see that there was something abnormal in that area, which was the AVM that was still there. And so we went back, did his angiogram, and now you can see, now that the brain swelling has gone away, and the brain is kind of had a chance to recover, we can see that the AVM is much larger than it looked like on that first angiogram, where the AVM was being pushed and compressed by the brain swelling. And you can see that early draining vein here. And on the side view, there's the AVM nidus, and there's the early draining vein. And so what I did was I went out with our tiny little Linguini microcatheters. This is the ICA, M1, M2, M3. M3 really is here, M4. So I'm getting out into an M4 branch. And we find the feeder that goes directly to the AVM. And you can see the draining veins. That's the draining vein. And there's the nidus of the AVM. And so then I inject Onyx, which is a liquid glue embolic material, to basically plug up that AVM. And so you see this is the microcatheter going all the way out. And this is me injecting the Onyx into the AVM to plug up that AVM. And we got to be careful, right? When we inject this material, we want it to go into the AVM and block the artery, but we don't want to block the vein, especially not early. Because what happens if you block the vein? Well, it's like plugging up your sink with drain, but leaving the faucet running. And if you do that in the brain, you will have the AVM increase, swell, and explode. And so that was the first feeder.
Michael, do pollo entero y una.
And we can see that we knocked this one out, but then there's one more to go after. And so then we go after the next one. So that just shows you that either we've already cut that AVM in half. And then here we are going after the second feeder. You can see that we've got to get out to this one. Here we are getting closer. Right? And then we injected more onyx. Let's see. And then here we are after the second. Almost completely gone. Just a small little what we call anterior choroidal indirect collateral. But you can see the glue cast there and where the AVM was and massively reduced shunting. So if you can compare the beginning from the pre and the post, this is the pre on the left, this is the post on the right. You can see how significantly we reduced that AVM. So we'll do follow-up in him. Hopefully over the follow-up angiograms, it'll progressively conclude itself. If necessary, we could always do additional embolization if it comes back, or surgery or radiosurgery to completely obliterate that AVM. And my last section, I know I'm running a little low on time, but we'll go through this, is brain aneurysms. This is an example, just a title slide with some coils inside a brain aneurysm, and you'll see this one in more detail. 56-year-old gentleman, grade 1, worst headache of his life. Fisher grade 4, meaning he had a lot of blood. He had blood in the ventricles, a very thick amount of blood, and he had a very large anterior communicating artery aneurysm. There is his CAT scan, and you can see all this white stuff. You see all this white stuff? These spaces are the subarachnoid spaces. They should be black like this, which is CSF, water. White stuff in the brain on a CAT scan is blood. And so you can see there's blood bathing all portions of his base of the brain, extending all the way up into the sulci. When we look at the angiogram, right internal carotid artery, cavernous, clinoid, A1 anterior cerebral artery, and then there's this huge ruptured brain aneurysm. And so what I do is I go up with a microcatheter inside the aneurysm, and we're filling it with coils. This is like you've got a rat hole and you're filling it with steel wool to plug it out so that no more blood goes through it. And so we start with, one coil, then we keep adding additional coils, filling it up as best we can to try to basically eliminate the blood flow within it. Here you see it's like a little blood flow going. And then we put more coils in and it looks like it's completely blocked. And so when we look at the final angiogram, no blood flow going into the aneurysm. We've blocked it up. So that looks great. I was very happy with this result. He did fantastic. He was in the critical care for 2 weeks. We had to do vasospasm prophylaxis, nimodipine. On the 5th day, I took him back to the angio suite to give him a little verapamil, which is the calcium channel blocker to help relax the blood vessels. So I often do that before they get critical because I try not to wait till they're super symptomatic, because then we're often found chasing our tails and having trouble preventing strokes. But obviously requires critical care. But then we brought him back for routine 6-month follow-up. I'd say 90% of the time, 6-month follow-up looks great. Unfortunately, in him, the aneurysm grew and the coils got pushed in even further. He had no symptoms, but you can see a significant portion of the aneurysm coming back. So I felt this was unsafe. I mean, I think the good thing is we got him through the acute phase, but I think long-term, this was going to be at risk for rupturing again. If an aneurysm ruptures, 1 out of 3 people die before making it to the hospital. And if the other people that do make it to the hospital, it's 50-50 that you come out functional and back to your normal independent life. So preventing an aneurysm rupture is always very important if we can. And so you can see this is a 3D that shows the coils and the recanalization of that aneurysm. So what I decided to do at this point was use a more advanced technique where we put what we call a stent into the anterior cerebral artery, which is basically, a tube kind of like, like a fence, that has it's a round fence kind of device. That's basically endoluminal kind of bypass. But what that allows is for me to more tightly, you can see the distal markers where it's open. There's only 3 markers that say it's open, right? And what that allows is for me to go through the stent with my catheter and put more coils in and more tightly pack that aneurysm so that we can plug it up at the inflow zone and prevent blood from going in and compacting the coils even further. And so here we are putting more coils in, more coils. And at the end, as the French like to say, voila, right? We have completely obliterated that aneurysm again. There's no blood going in once again, right? No black stuff in between those coils, and he did great, and so we're going to have to follow him up again in 6 months and make sure, but I'm hoping we've killed this ugly gorilla. And so we'll put him on dual antiplatelet therapy for 3 months to allow the stent to heal. Do a follow-up angiogram in 6 to 12 months to make sure we've got a durable result. And I suspect we will. And so brain aneurysms, AVMs, and dural fistulas remain an important cause of bleeding or hemorrhagic stroke with potentially devastating consequences, as we've talked about. In modern day neurovascular care, endovascular therapy is often the first and front line. So we can often treat most of these patients with neurointerventional techniques and minimally invasive treatments with low risk and low morbidity. Although surgery and radiosurgery remain important tools in our armamentarium, and we often combine, especially for brain AVMs, multiple modalities of treatment. For brain aneurysms, I would say 90 to 95% of the aneurysms are now treated endovascularly, and that open surgery is rarely required. So key takeaways: suspect hemorrhage generously. Headache, bad gas-Guyot scale, hypertension, very bad blood pressure, think hemorrhage. Use be fast every time. Pay attention to balance and eye symptoms in addition to face, arm, and speech. I think that will increase your sensitivity for posterior fossa syndromes and alert the EDs when you get there. Apply one of the validated LVO scales. I think we're using the Cincinnati. I think as there's new scales that come up, I think that it's not that hard to learn. And you can obviously use the Cincinnati scale, but if you can see, if you're aware of some of the other tools, then, if you see eye deviation or you see neglect, you see some of these other features, use your scale, but let the ED know that you also see the other stuff, right? That'll give them a heads up and to be more aware that this could be an LVO. And, know your perfusion windows. Really, there is, these days, almost no window. I would say 24 hours is kind of the standard what we use, but I'd say even out to 2 days, 3 days, sometimes, especially if you don't know when they had their last normal, treat it as if it's an emergency. Bring them to the emergency room. Let us figure out whether or not that's somebody that could benefit, because there are many patients that, even further than 24 hours, that have a large amount of, salvageable tissue that we can potentially save. And I think, I know time is brain, but I think time is brain is, kind of not completely the story. I would say physiology is brain, meaning it depends on your collateral circulation, depends on where the stroke is, it depends on a lot of factors. And we shouldn't exclude people based on time alone. We should have these advanced triage protocols, which involve obviously clinical exams and imaging and all the rest. And I think destination, as we discussed, as Brian mentioned, is systems dependent. It really depends on your local area. Right now, I think we're doing an incredible job with our primary stroke centers in Catholic Health. And I think that, ultimately, I think it would be great if we could increase the capabilities at these local stroke centers, primary stroke centers, and make them thrombectomy capable as well. I think one of the, themes that I've always tried to, that I've been over the last 20 plus 25 years is that, sometimes it's better for the doctor to run. In other words, I can go to St. Francis, or I can go to Mercy in about the same amount of time, rather than have the patient be transported. And I think that's something that I think we're going to try to do more in the future. Is keep the patient in this primary hospitals, and I think that will make it for more efficient care and as well. So I think that is my last slide. Other than, oh yes, yes. So just a final thank you guys, and I hope you got a good summer. This was my wife and I last spring, doing some bike touring in the south of France, which was a lot of fun. I would highly recommend it if you ever get a chance.